So we can start in 3, 2, 1. Please go ahead.
Good morning and good evening to all eminent faculty members and participants who have joined from various parts of India and abroad. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Astrid from Argentina, all discussants and participants to this virtual symposium on lymphoma and update. Before we commence the proceedings, I would like to welcome and introduce the host and the convener for this continuous medical education series under the edges of Mumbai Hematology Group, Dr. M.B. Agarwal. Sir is Professor and Head Department of Hematology, Bombay Hospital Institute of Medical Sciences, Mumbai. He is also associated with other esteemed institutes like PD Hinduja Hospital, Leelavati Hospital, Fortis and Breach Candy Hospitals in Mumbai. He is the president of Mumbai Hematology Group as well. I request Dr. M.B. Agarwal, sir, to navigate this program further. Sir, over to you.
Can you see my slide?
Yes.
Okay.
Yes, sir.
Thank you so much, Mr. Sumit. Good evening to one and all from India, and good morning, good afternoon to the rest of the people from the rest of the world. Today, we have our guest speaker, Dr. Astrid Paulowski from Argentina. She has been our speaker in past as well, and I'm sure most of you have heard her. She's a wonderful speaker, a great teacher. We're very fortunate to have her again and again for these webinars, which are so important for us. Today, she will be lecturing on relapse refractory follicular lymphoma. What options do we have in 2025? This webinar, as usual, is brought to you by Mumbai Hematology Group. It is supported by Zydus, and it is managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan, and the team from Zydus, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, the Executive Committee of Mumbai Hematology Group. Of course, most importantly, our guest speaker of the day, Dr. Astrid Paulowski from Argentina, all our discussants who are eminent hematologists or medical oncologists from India, and you participants for sparing your Saturday evening, morning, afternoon. Tomorrow morning, we have Dr. Anjali Kedkar from Pune speaking to us on artificial intelligence in diagnostic hematology. And this will be brought to you by Mumbai Hematology Group at 11:30 a.m. on Sunday tomorrow. Our discussants today include Dr. Aditya Jandial from Chandigarh, Dr. Amit Khurana from Surat, Dr. Akanksha Garg from Ahmedabad, Dr. Avriti Baveja from Dehradun, Dr. Bharat Parikh from Ahmedabad, Dr. Chirag Shah from Ahmedabad, Dr. K.K. Radhika from Hyderabad, Dr. Mahadev Swami BC from Goa, Dr. Malikarjun Kalashetty from Bengaluru, Dr. Manoj Unni from Kochi, Dr. Prashanta Bhatt from Mangaluru, Dr. Rajani Priya Yedla from Vishakhapatnam, Dr. Rajkumar Ramaswamy from Madurai, and Dr. Satish Kumar A from Bangalore. Dr. Astrid Paulowski does not require any introduction. I'll just give a very brief introduction of hers for those who are joining us for the first time. She's Medical Director of Paulowski Center, Department of Hematology at Fundelo, Buenos Aires, Argentina. She's a specialist in internal medicine and hematology. She graduated from medical school with honors at the University del Salvador, Argentina in 1997. She completed training in internal medicine at Hospital Italiano di Buenos Aires, Argentina for 5 years and continued her training in Fundelo as a fellow in hematology in Buenos Aires, Argentina. Today, as I said, she will be speaking to us on relapse refractory follicular lymphoma. What options do we have in 2025? I'll stop here and I request her to give her talk.
Okay, thank you very much. Thank you for this kind introduction. And I will share my screen. Now I think you can all see my screen.
Not yet.
Now?
Yes.
Okay. So thank you very much. It's a pleasure for me to join you, and I congratulate you on this great organization and share and being on a Saturday evening to learn more about hematology. So we are faced to a fact of relapse refractory follicular lymphoma, and we do have many new options. So the big challenge is how to choose within these options. When we look at follicular lymphoma, there are these very famous and well-known curves, but I think that it is something that we really have to keep in mind when we see our patient for the first time. And what do these curves show us? In the blue curve, and which is very important, is that most patients will live for a very, very long time, and some patients might not even die of follicular lymphoma. So it's important to keep that in mind, because we are not trying to only cure quickly and aggressively in first line, but we're trying to make this patient live a long life with the little harm, trying to give the less therapies that we can give them. But on the other hand, we know on the yellow line that progression-free survival doesn't have a plateau, and that eventually, as time goes by, many of these patients will eventually relapse. So these are two things that we need to keep in mind, because this is different from other lymphomas where we're trying to cure them with first-line treatment. So when we try to predict how these patients will go, when we first see them, there are lots of different prognostic models to predict outcome in first line. We have the FLIPI, which is very easy, and we can all apply them in everyday clinical practice. We have the FLIPI-2, which incorporates beta-2 microglobulin. We have the PRIMA-PI, which is also very easy, which is beta-2 microglobulin and involvement of bone marrow. And then we have another factors that involve molecular determinations, which are not used in everyday clinical practice. But we can see that most of these can talk about progression-free survival, but as I said before, most patients will live for a very long time, so this will not predict very well differences on overall survival. But there's one thing that has been found as very important prognostic factor, and this is the time to relapse. For patients defined as POD24, and POD24 means progression of disease within the first 24 months of therapy. So why is this important? Because by the time that patients relapse within this first 24 months, there's nothing that we can do, because the defining of these high-risk patients is when they relapse. But this is important because this is something that has a lot of influence on overall survival. And we can see in these curves that the survival probability is a lot lower in those patients that have an early relapse, that have relapsed within the first 24 months, compared to the reference group. And this is also another database where also defines the same thing. So patients that with POD24 had a 2- and 5-year overall survival of 68% and 50% respectively, versus 97% and 90% in patients who did not relapse within the first 24 months. So this is very important, because when patient relapses, we know that if the patient relapses within the first 2 years, we are facing with a much more difficult to cure follicular lymphoma. And this is around 20% of the population. Now, can we quickly or correctly identify this group of patients with high-risk follicular lymphoma? And no, there's still no way that we can in a correct way identify these patients with POD24. So we can see here all of the different prognostic factors actually overestimate a bad risk groups, patients who will not relapse. And there's a proportion of patients in POD24 from different databases, from the German and from the Canadian database. There's a proportion of patients that we will not identify in spite using any of the prognostic factors. So at first line, at this moment, we all treat patients the same. We are unable to adapt first-line treatment to those who have an event within the first 24 months, because we cannot identify this group of patients at diagnosis. So this group of patients, as said before, they are around 20% of the patients. These patients with early event after immunochemotherapy, now this is important, this is after immunochemotherapy, represent the greatest clinical need in follicular lymphoma. And this newly defined high-risk group of patients represent a very distinct population from other follicular lymphomas, but we are still not able to identify them either with biology or with baseline features. Now, are there some misconceptions regarding POD24? Are all POD24 the same, meaning that all patients that relapse within the first 24 months will have the same prognosis? And let's look at this. First of all, there is a large difference regarding the treatment. So we have to keep in mind that this group of high-risk patients are those that relapse after immunochemotherapy. If we look at patients that have received rituximab, monotherapy, and maintenance, when they relapse within the first 24 months, the overall survival is the same. So there's a big, so once again, keep in mind that this is only after immunochemotherapy. And there's also a big influence when they relapse if they have histologic transformation. So what is the risk of having a histologic transformation? There's a 10-year risk of about 3.6% in those who received rituximab at induction and at maintenance. There's some evidence that giving rituximab as maintenance can reduce histologic transformation. The 10-year cumulative incidence is about 10%, meaning it's about 1% a year. And the majority of patients who actually die of follicular lymphoma will have a histologic transformation at their last event. So let's look at this in some graphics. This is the Spanish group, and we can see that with a very long follow-up, the risk of transformation goes up as years go by. And as said before, it's around 10% at 10 years. And the survival after defining histologic transformation is very low, with a very small plateau of around 20%. And here we see something about POD24. If we divide those patients that relapse within the first 24 months, and we divide them within those that have relapsed with persistent follicular lymphoma histology, and this is in the blue line, although there is an influence in prognosis, these patients don't do so bad in overall survival. And actually, the patients that have the big influence on the bad prognostic of POD24 is because a high proportion of these patients relapse with histologic transformation. So let's look at this in an example. This is the Canadian experience. 296 patients were treated with BR and maintenance with rituximab. 13% in this group had POD24, and of these 13%, 76% had a histologic transformation at relapse. So we see the group that had POD24, with histologic transformation in overall survival, and those who did not have histologic transformation. So we have to keep in mind that when patients relapse very early, histologic transformation is a frequent event and and has a lot of influence in prognosis. And here we see it again in different groups: the Spanish group, a group from the United States, and in the Gallium group. When patients relapse with no histologic transformation, there is an important factor in prognosis, but not as bad as those who relapse with histologic transformation. So once again, the most important risk factor at relapse is histologic transformation. So this leads us to what should we do when patients relapse? First of all, we have to always biopsy. We cannot think that patients do have follicular lymphoma at relapse because we have a previous biopsy. And something else that we should not do is that we cannot define histologic transformation only by the SUV. For some years ago, when we first started using PET, it was said that if patients had SUV more than 12 or high SUV, we almost have to think that they do have a histologic transformation. Well, further follow-up on the studies have shown us that there are some, and here we see that there are some patients that relapse with histological transformation and they have very, very low SUV at 7.5. And then we have patients that relapse with histologic transformation and they have very high SUV in basal PET as 32.5. So definitely when we see a very high SUV, we have to think about it, but it doesn't define the mean of histologic transformation, but we might use PET-CT to choose which site of the patient we would like to biopsy. So this is very important things about when patients relapse. Always biopsy first. And something that we have to keep in mind, even in patients with POT24, if patients relapse with follicular lymphoma histology, all asymptomatic patients can have an option to be observed again. Relapse doesn't mean that we need to treat our patients again. Remember the first two curves that I show you, I think we always have to keep that in mind. So all patients, chemoimmunotherapy can be an option. So if patients have received chemoimmunotherapy in first line, we can again give them chemoimmunotherapy. It depends how long the response has been. All patients can be considered for rituximab maintenance again. And there's a very small proportion of patients in whom we can consider consolidation with autologous stem cell transplantation at first relapse. And this is especially patients that have relapsed very early, especially those with POT24, and that do respond to second-line chemoimmunotherapy. For this group of patients, autologous stem cell transplantation can be a curative intent. So let's look at the European guidelines. They say more or less the same. We have to reevaluate our patients. And if patients are asymptomatic, watch and wait can be an option. If patients have mild symptoms, maybe we can treat them with monotherapy with rituximab. And patients with high tumor burden, we can consider different lines of immunotherapy. And always, lenalidomide plus rituximab is an option together with chemoimmunotherapy. What chemoimmunotherapy will maybe what we have not used in first line. For example, if we used R-CHOP, we can give R-bendamustine. If we used R-bendamustine, we can give R-CHOP. And the same thing is said in the NCCN guidelines. Preferred regimens is chemoimmunotherapy or rituximab lenalidomide, which has shown different toxic profile, but the same response in relapse setting. And we can use maintenance. So what about, let's talk, because we know a lot about chemoimmunotherapy. What about using lenalidomide in a second line? And this is the Archman trial, which shows us that lenalidomide plus rituximab is also a good option with a PFS at 3 years, which is almost 60%, and a very good and long overall survival. So this can be an option. It depends on different things. It has its benefits of being an oral regimen. And another option is lenalidomide plus obinutuzumab, especially for relapse for rituximab refractory patients, also offering a very good overall survival probability for this group of patients. So this is another option that we have in second-line therapy. So how do we treat these patients? Guidelines recommend to treat patients according to clinical presentation, whether they need or not therapy, and according to patient's fitness. There's no molecular factor, and there's no risk-adapted strategy that can be recommended at this time. And what about this other group, which is a very important group, which is the double refractory or third-line therapy? Double refractory means those patients that have received 2 lines of chemoimmunotherapy. What options do we have for this group of patients? And when we looked at all the approved options we have had in Europe and in the United States, different approvals for this group of patients. Now, for some years, we had the approval of duvelisib, umbralisib, and idelalisib. But as time went by, these different drugs shown increased toxicity, mainly gastrointestinal toxicity, so they have been removed from the options. So what options are left other than chemotherapy? As said, lenalidomide plus anti-CD20, tazemetostat, and then we have CAR-T and bispecifics, and a new regimen, which is zanubrutinib plus obinutuzumab, which we'll now deal with. So let's look again at the guidelines. Still, there's no specific recommendation according to risk classification. So all of these options have to be taken into account, considering the real options that we have available in our country and the patient's characteristics. What about CAR T cell therapy? We don't have them available in Argentina, so I don't have personal experience, but I will talk about the results and also bispecifics antibody. So these are the three big trials with CAR T in relapsed refractory follicular lymphoma, the axi-cell, the TISA-cell, and the liso-cell. We see that all of these patients were high-risk patients with a high FLIPI, or most of them, or a high proportion, were double refractory, and also a high proportion were these patients that we considered high risk, which were the patients that had relapsed within the first 24 months. So more than 50% of them, and a very high proportion, were refractory to last line of therapy. So these were truly high-risk patients. And what we see that there's, if we consider the whole of the CAR T cell, more or less there's about 80% CR rate. So these are very good options. And for those patients that achieved a CR, the progression-free survival and the overall survival is very high. Look, we see that the median progression-free survival was not reached in most of these studies. So for patients that have a CR after CAR T, the prognosis is very good. And as seen here, in most countries, these CAR T cells have been approved for third-line therapy. If we look at whether these patients, whether CAR T has an influence regarding bad prognostic factors as early relapse, POD24, or double refractory, we see that even these high-risk patients have a very, very high CR rate after CAR T cell therapy. So we have to remember that maybe when we're going to look at CAR T and bispecifics, previous prognostic factors that we had adopted after chemoimmunotherapy might not be such have such influence when we look at cellular therapy. And once again, I show you that patients in CR have a very good progression-free survival after CAR T. And then we have these new options, mosunetuzumab and epcoritamab, which have both been approved for patients with relapsed follicular lymphoma for third-line therapy and as monotherapy. So this is a long-term follow-up for patients who had received, as said before, more than 2 lines of prior therapy and that have received monotherapy with mosunetuzumab. And once again, we see that CR is 60%, and this is very important because most patients that achieve a CR achieve the CR very quickly after starting therapy. So maybe after 3 cycles of mosunetuzumab, we can determine by a PET-CT whether this patient is in the good prognostic group that has achieved a CR and will eventually have a very long-term progression-free survival. So as said before, 60% of the patients achieve CR, and most of these patients that have a CR after 3 cycles will achieve a CR after end of treatment. So we see that CRs are very, very durable with a 24 months duration of CR of 65%. Who are the patients that achieve a CR? Can we determine before starting treatment? And we can see that all of these bad prognostic factors that we had in mind after immunochemotherapy don't really influence on the response to mosunetuzumab. So patients with POD24 also have a very, very high chance of achieving a CR after mosunetuzumab. And here we see it in graphic. Patients who had no POD24 or did have POD24 have the same or statistically the same CR. Patients who were younger or older than 65 also have very good prognostic factors. And it seems, but this is not statistically important, but maybe patients that receive it earlier during treatment after third line or after fourth line can have a better response. So CR rates across all high-risk groups were consistent with the overall population, and higher rates were observed for patients that received it after only 2 other lines of therapy or compared to 3 or more lines of therapy. And exactly the same information we see with epcoritamab. So there's really there's not a lot of scientific information whether one bispecific antibody is better than the other. So what do we know from these bispecifics in follicular lymphoma? The FDA has approved in December 2022 mosunetuzumab, in March 31 odronextamab, and in June 26 of 2024 epcoritamab, and they all have been approved for the same group of patients, relapsed or refractory follicular lymphoma after 2 or more lines of systemic therapy, and they were all approved as monotherapy. And this is, I think, the newest option that we have, or at least newest in my country, which is another option, which is zanubrutinib plus obinutuzumab versus obinutuzumab as monotherapy patients with relapsed or refractory follicular lymphoma. This is called the Rosewood study, and also patients that had received 2 or more lines of therapy were included, and they were randomized in a 2-to-1 basis to receive zanubrutinib plus obinutuzumab or monotherapy with obinutuzumab, which I don't consider this a good option, so I won't even mention this as a good alternative for third line. So what we see in this group of patients with this new therapy, zanubrutinib plus obinutuzumab, the CR rate was almost 40%. And the median time to next treatment, I think this is a good endpoint, time to next treatment, because some patients can progress but not need a new treatment. And time to next treatment was not observed, was not reached in this group of patients. And here we see it in a curve. We see that progression-free survival, the median progression-free survival was 28 months compared to 10 months. But as I said before, the standard arm is not very strong, but we know that this group of patients have a very good prognosis after this line of therapy. And for those who achieve a CR, the median duration of CR was not reached. So even in new therapies, achieving a CR with a negative PET-CT is a very important prognostic factor. And the benefit of this combination was seen across all subgroups. So what is the best third-line treatment for follicular lymphoma? Well, there's not just one winner. I think that it would be great if we can have different options. And the big challenge for us as hematologists will be to select the best treatment sequence in a very personalized way, because it's true that many of these patients might need more than 3 lines of therapy. So we don't not only need one winner, but we need different options. So what do we know today? We know that we have been saying for a long time that follicular lymphoma cannot be cured. Well, I think that there's a proportion of patients that will never need a new treatment after first-line therapy. And this is what is now called a functional cure. We cannot say they're cured and still many, many years have gone by and they never need a treatment. But relapse is a frequent event, but not all patients will relapse. So we have to stand by and see how everyone goes on. And what is the most important and what is the big challenge? And why do we don't know? There's so many different options for these patients because they have a very clinical heterogeneity. Some patients can relapse early and then stay stable for many, many years. And some patients relapse after many, many years when we thought that maybe they were cured. So there's a big heterogeneity. And that is our big challenge, is to follow our patients and try to make personalized decisions. Still, chemoimmunotherapy still has a role in this group of patients, and novel approaches give you new options, making therapeutic decisions often difficult. So we need to take into account previous treatment, the time to response, the time that they have been without need of another treatment, and the physical fitness of the patient when we're going to decide second or third line treatment. This wide availability of new therapeutic treatment is definitely improving prognosis in these patients. And today, with bispecifics, CAR T-cell therapy, and zanubrutinib, we even high-risk patients may enjoy a prolonged long-term survival. At the present time, we do not have reliable prognostic factors in which to base our sequencing of treatment, so the parameters affecting these decisions have to come from our own examination, and including all our thoughts that can include the number and the type of previous lines of treatment, the clinical presentation, and the patient's fitness. So thank you very much. I will now stop sharing, and I am open to any questions. Thank you very much.
Thank you, Dr. Pawlowski, for that wonderful update. We learned a lot. Everything was crystal clear. You made it very simple as well. So we'll have questions from our colleagues who are all here. Meanwhile, may I put one question to you? What is your starting regimen, BR or R-CHOP?
Okay, that's very good, and it has changed. I think what patients receive depends on where they were born, because there's, in the United States, most patients start with BR. In Europe, many patients can start with R-CHOP. I usually start with BR. I think it gives better quality of life for our patients, but also bendamustine has some important toxicity, especially long-term leukopenia. So we have to manage also the dose of BR and keep in mind, and also the long-term infection rate of starting with bendamustine. But I start mainly with bendamustine.
In the era of these two regimens, is there any place for our CVP?
Well, we used to use RCVP for unfit patients. I think RCVP is effective, but not as effective as bendamustine or R-CHOP. I don't think it's wrong to choose RCVP. I don't use it as frequent, because between RCVP and R-bendamustine, I might use R-bendamustine. But why do we have so many options, especially in first line? Because many of these patients respond to many therapies. So maybe we give RCVP and patient has a very long-term a good outcome. So it's not a wrong option. We can keep it in mind. Depends on where you work and what's the patient's characteristics.
Will you suggest a maintenance therapy for all the patients?
That's a very good thing, and I think maybe the question is, do we think progression-free survival is a good objective, or do we have to look at overall survival? So it depends maybe on the age of the patient. If I am treating a patient who is 50 years old, I think that progression-free survival is very important, because if this patient does not need another line of chemotherapy for 15 years, this is very important. So I do offer rituximab maintenance to these patients. For older patients, where maybe having 5 years progression-free survival is good enough, maybe I balance between infections and maintenance therapy. So maybe in these patients, I talk with the patient, I show them the good and the bad things, and clearly the downside of maintenance are infections. Patients do have a higher chance of infections while they're on maintenance. So I do like to give or to offer maintenance for our patients, but I also think it has to be dealt in a personalized way.
Will you ever use obinutuzumab upfront?
Yes. Yes, I think there's a small group of patients in which obinutuzumab has made a difference even in overall survival. And these are for young patients with a high IPI. So young high-risk patients with obinutuzumab and bendamustine have a higher probability of having a CR or a negative PET-CT after induction. And this translates into overall survival and have a lower probability of POT24. And this also translates on overall survival. So for this group of young high-risk patients, I choose to give them obinutuzumab in induction, and I offer them maintenance therapy.
Any place for lenrituximab upfront?
I'm sorry?
Lenalidomide, rituximab upfront?
Lenalidomide, yes. I don't use it in my everyday practice. It is not approved in my country, but it has shown to be as effective as chemoimmunotherapy. So if some patients can receive it depending on the country, it's also a very easy to deliver regimen and can be an option with a different toxic profile, but almost the same efficacy as chemoimmunotherapy in first line.
Sure. Satish, your question.
Thank you, sir. Thank you, Dr. Pawlowski. Enjoyed the discussion. So if there is a fit patient with relapsed refractory follicular lymphoma, third line, how do you choose? You said patient to patient, we need to personalize. So if we have all the three options available, salvage and autologous transplant, zanubrutinib plus obinutuzumab, and bispecific antibodies, how do you decide which is the best if he's a fit patient and he can tolerate all the three therapies?
Okay, I will only think about autologous stem cell transplantation in a patient that relapses very quickly after chemoimmunotherapy, in which I think that another line of chemoimmunotherapy alone will not give them a good opportunity. So only in a very small group of patients with early relapse, high-risk disease, and young patients, I might consider autologous stem cell transplantation. But that was all of the trials that showed the benefit of autologous stem cell transplantation were in an era where we didn't have bispecifics, we didn't have zanubrutinib, and we didn't have CAR-T. So we don't know whether the patients that do not go to autologous stem cell transplantation can be rescued with these other lines of therapy. So I think there might be a role for autologous stem cell transplantation, but it's a very small role. And then I think that considering all of the other options that you just mentioned, we do not have CAR-T cell therapy, so I am not offering a CAR-T, but bispecifics are a good option. And I think there are two good things. First, that we very quickly know if the patient is responding. And also this is, economically important, because we're not going to give 15 cycles of bispecifics in a patient that is not responding. So I evaluate my patient after 3 cycles, and those patients who have a CR, those are the patients in whom I would continue therapy. Now there's some bispecifics that have a limited time therapy, which is only 8 cycles. The tolerance to bispecifics has been very good in my experience. You have to be prepared to treat CRS, you have to have tocilizumab, you have to be prepared. But I think bispecifics are an excellent option. And for patients who cannot receive bispecifics, mainly due to the lack of availability of these drugs, zanubrutinib plus obinutuzumab is also a great option. So in third line, I think these are the two most important options I keep in my patients.
Because even in the trials of bispecifics, you showed that patients who had undergone transplant, the results are not as good. Like I think it was 30% or so. So post-transplant bispecific antibody patients don't do so good, I feel.
Well, I think that these group of patients that went on to autologous stem cell transplantation are
earlier.
patients that had bad prognostic factors. So I don't think it's the problem was not autologous stem cell transplantation, but maybe the quick
Disease
relapse
biology.
rate.
Right. And how about transformed follicular lymphoma? How do you treat them? Richard's transformation.
Okay, so this is a big, great topic, and I treat them as diffuse large B-cell lymphoma. There's no doubt we need to treat them aggressively as diffuse large B-cell lymphoma. If patients have not received anthracycline because maybe they did not receive it in first line, I think anthracycline needs to be delivered to this group of patients. And in this group of patients, I do consider autologous stem cell transplantation as consolidation.
So R-CHOP followed by autologous transplant if they're in remission.
Exactly. R-CHOP, or yes, or if they had already received and they failed R-CHOP, maybe a salvage chemotherapy as RIs or ESHAP, and consolidation with autologous stem cell transplantation, and no maintenance for these patients. These are patients that have to be treated as diffuse large B-cell lymphoma.
Thank you. Thank you, sir.
Thank you. There's a question with the audience. Is there a role of MRD in relapsed follicular lymphoma?
Yes, sure. There's an important role considering prognosis of MRD negative. Definitely patients that are MRD negative have a better prognosis, but there's no role to adapt therapy to MRD negative. Even in first line, I think this was a surprise for me. The Italian group in the FOL12 trial showed that even patients who were MRD negative and PET negative did have benefit of maintenance with rituximab. So I think this was a surprise because I thought that those patients might not need maintenance. So this is the importance of having clinical trials. So I think MRD negative is a very important prognostic factor, but it's still not ready to be used to direct therapy according to MRD.
Another question from the audience. Because of the grade of follicular lymphoma, if it is 3A, will you prefer R-CHOP over R-BENDA for grade 3A?
Okay. Well, I think this depends very much on the confidence you have on your pathologist, right? Because if it's not easy, I am not a pathologist, but I think it's not so easy, and you have to have a very experienced eye to differentiate between 3A and 3B. If patient, and I do trust my pathologist, she's Marina Narvaez, she's a great pathologist. And if she says it's 3A, I just treat it as a follicular lymphoma, and I am comfortable with choosing bendamustine.
Another question is, in an asymptomatic patient, if there is a progressively increasing lymphadenopathy, do you intervene?
If in an asymptom, well, it depends on where that adenopathy is, because some patients have an adenopathy that gives no symptoms and no risk. And I think that waiting and gaining time, it's a very big success. And also, as I tell my patients, sometimes progression is like, it's not always like that. Sometimes they give like they go up and then they stable, and then they go up and stable. So I think you need time, you need follow-up to make the right decision. And I always tell myself, and I tell my patients, that most time follicular lymphoma gives you time to make a good decision. So there's no rush if the patient has no clinical symptoms, as this example who is asymptomatic and has no risk. There's no risk regarding the progression of that adenopathy. You can always watch the patient, and then with time, you will be more sure about the decision you are making.
Right. Chirag, your question?
Yes, thank you, sir. Thank you, ma'am, for a very lucid talk. Earlier, there was a lot of talk about allogenic transplant in follicular lymphoma having the potential cure. Now, the newer options that you mentioned, the bispecific, CAR-T, and Xanu, uh, all three would be cheaper than allogenic, I mean, costlier than allogenic transplant in India. Uh, would there be a subset where you would consider allo?
Okay, that's a very good option. I'm also from Argentina, so economy is not also great. There is a big risk of treatment-related mortality in allogeneic transplantation. So maybe we can find a few patients that might benefit from this strategy, but it is definitely not something that I keep in mind to offer a large proportion of patients. Okay, as said before, most patients will live a very long time, so we only have to choose a very small proportion of patients that we can think that this patient will actually die very soon due to progression of follicular lymphoma, and that is not a large proportion of patients. So allogeneic transplantation might be considered in a very small group of patients, but I don't recall in my clinical practice indicating allogeneic transplantation in any of my patients. Even autologous stem cell transplantation is a small group of patients.
The other question about the bendamustine rituximab. Now, uh, as you mentioned, some of the patients have severe cytopenia and infections. So once we start, is there a way after, say, 2 or 3 cycles, we get a sense that these patients are more likely to have that, and then maybe we stop at 4 cycles or cut down the dose or some practical way to avoid long-term issues?
Absolutely. I think that we always have to keep in our mind a good balance between efficacy and toxicity. And there's a published trial about 4 cycles of Arbenda, PET negative, and stopping therapy. And it was a positive trial. And I trust evaluation of disease by PET. So I think patients who are PET negative, and also patients who might not be PET negative, but who have a very good response and are being affected by toxicity, I definitely think that stopping therapy can be considered. Absolutely. We have to cure our patients, not only have a PET negative. So, and quality of life is a very important thing in patients with follicular lymphoma.
Earlier, there was some mention about not using rituximab maintenance after benda rituximab because of the
Absolutely.
risk of infections.
Absolutely.
But then I read a study that it made a difference there also, and they're giving. So how can you guide us?
So I think the first trials were suggesting that we should not give rituximab maintenance in patients that have received bendamustine. And then we have following trials, the gallium and other trials that have shown, the fall 12, that have shown that there is a benefit when using maintenance in patients that have received bendamustine in induction. So once again, I think that it's a straight talk with the patient. There is a higher risk of infections. Yes, there is a higher risk of infection. So I usually offer my patient maintenance after this explanation of infection and progression-free survival and about no benefit in overall survival. We have to keep that in mind. So again, maybe young fit patients are better candidates to do maintenance other than older patients in which maybe 5 years of progression-free survival is a good goal to aim. So I do think that there is a role, and it's safe, not safe, but it's feasible to give maintenance, and we have to keep balance. I also stop maintenance in patients that have had, repeated respiratory infections, sinusitis, and have a very bad quality of life due to these minor infections, I also stop maintenance.
You don't do IVIG any of these patients?
Not prophylactically,
No.
not prophylactically. Only on patients that have very low gamma globulin and that have 3 or more serious infections during the year, but not in every patient, definitely not.
And so last question,
Yes.
Any role of, instead of 2 month or 3 month, maybe a longer frequency of rituximab maintenance? Is there, say, over the time, can you make it 4-6 months?
Well, I think there's no comparison between every 2 months or every 3 months. There was a trial at the beginning every 2 months and then every 3 months, and they were both positive. So there is no comparison. So it's fine to give it every 3 months. And I also keep in mind these 2 years that are mentioned in part 24. When you see that a patient has achieved 24 months after initiation of therapy and the patient has no signs, and if the patient has a toxicity, I think it's safe to stop maintenance. And also keep in mind that there's no difference in overall survival. So, we have to rethink about maintenance in every patient.
Thank you.
Thank you. Dr. Akanksha.
Yeah, thank you, ma'am, for the very lucid talk. So, in continuation with the previous discussion that we were having regarding the maintenance, so I have a question that, if a patient decides that they do not wish to receive a maintenance rituximab, so is there any difference in the follow-up that, the schedule of follow-up or the imaging that you would do in such a patient vis-a-vis a patient who is on the maintenance with rituximab?
Okay. So this is a very good question, and I think every doctor has their own way of doing a follow-up in follicular lymphoma. I don't follow them up. I don't do different follow-up. I think it's very important to do a good interrogation to the patient and physical examination. I am not sure in your country, but I see some that just ask for CT scans and they never touch the patient. So I think it's very important that we do a physical examination. I do most of my follow-ups with physical examination. Maybe in some patients, I do ask for a CT scan at 2 years just to have this, prognostic factor. And then I never do a PET CT if end of treatment PET was negative. And then I follow most of my patients with physical examination, with interrogation, and with sometimes as we do follow up, I might ask for an ultrasound of the abdomen or CT scan in high-risk patients, but I don't routinely ask for images in any of my patients.
Okay, ma'am. And ma'am, my second question is that, at baseline, I mean, we've heard of the various molecular prognostic markers. So is there any role of doing a molecular evaluation for patients who have advanced stage disease and follicular lymphoma? And if yes, then would it affect the management in any way? I mean, what are your comments on that?
I use traditional prognostic factors. I don't think anyone has wide availability for molecular determination at baseline, and none of these molecular prognostic factors at baseline change the intensity of first-line therapy. So they might be prognostic factors, and I am not able to ask for any molecular prognostic factors at baseline. So I don't use them to manage my patients.
Okay, thank you so much.
Just one question out of your answers. If you are not doing imaging after 2 years, then your POD 24 is clinical judgment?
But it's not a rule. It's not that I am not doing it. I am just don't routinely use. It's not like every 6 months or I try to have clinical judgment on the patient. For example, if the patient previously had a retroperitoneal mass, which I am not going to be able to do at physical examination, I am more keen to ask for some CT or ultrasound. And if the patient has not been evaluated for a very long time, then I might do an image. But I don't, if we think that these patients will probably live for a long time and they might relapse, but in many years, then we are going to ask for a lot of different CT scans that will not give us an opportunity to make decisions. Also, we need to think that if we have a patient that is asymptomatic and might have in a CT scan a 3 centimeter adenopathy, maybe we're not going to change treatment. So I do images in patients with follicular lymphoma, but I try to put in clinical judgment and personalize in every patient.
So if there is a relapse at one node, will you ever radiate it?
Yes, sometimes yes. If patient has had, yes. So this is, the art of medicine. Not everything is the same for all patients. But if patient has had only one node and this node is big and it's growing, maybe radiation can buy us some time. And to have good time without therapy in these patients is a success. So yes, radiation can also be included.
Dr. Rajani, your question.
Good evening, ma'am. That was an excellent talk. So I have a case, ma'am. So recently, I have a 40-year-old female patient. She's very anxious. She was diagnosed to have a grade 2 follicular lymphoma, stage 4 at presentation with bone marrow involvement. So she has indications for treatment in terms of more than 3 nodal involvement and a bulky nodal disease at presentation. So I started her on bendamustine rituximab combination, completed 6 cycles, end of therapy PET CTs in CR. So she was on follow-up for almost 1 year. So recently, I had got LDH and CBC. As follow-up, I do CBC and LDH for my patients. So the LDH was elevated, and clinically also there are cervical nodes which were palpable. So I got a PET CT scan done. So it was suggestive of relapse. So many nodal areas were involved above and below the diaphragm. So I got a biopsy done. So it's again it's not a transformed lymphoma. So she progressed within 12 months. So my question is how comfortable, as of now, she's not symptomatic. Only just because I have clinically suspicious nodes, I got the scan done. She's asymptomatic. So from the talk which you had given, so she's not having any indications for treatment as of now. But being an young patient with an early relapse, so how comfortable are we in keeping the patient on follow-up? Or actually, my plan was to give her R-CHOP and take up for transplantation. So how do you proceed about treating this patient, ma'am?
Okay, yeah, this is a very good case. This is a patient who would be in the group of pod 24. She actually would be in the group of pod 12. So she is a high-risk patient. You can buy some time by doing watch and wait if the patient is asymptomatic. I think maybe the personal project of the patient. I recently had a patient that was, well, a few years ago, I had a patient that was very similar, and he had just won a scholarship to go overseas to do a 1-year training. And he went overseas, he did the 1-year training, and when he came back, he did a chemotherapy. So I think this is someone you have to watch very carefully. You can do watch and wait if you're able to do a very careful follow-up. But I do think that this is a patient in which we can consider salvage therapy and autologous stem cell transplantation, as you said.
Okay, thank you, ma'am. The other question is about the rituximab maintenance. It was answered in the previous questions, ma'am. So many of us previously used to give rituximab maintenance, but after COVID and many of us stopped using rituximab maintenance as well. We are just keeping the patients on completing 6 cycles and keep observing the patients. So is there any role of rituximab maintenance in patients who are having a partial response?
Yes, absolutely. Yes. even in patients, there's absolutely a role in these patients. Even in the gallium study, it was shown that many patients who at end of treatment have a positive PET scan afterwards had a negative PET scan after maintenance. And patients who achieve a negative PET scan after maintenance have such a good prognostic factor as those who achieved a negative PET scan after end of treatment. Yeah. So there's definitely a role for maintenance in patients with CR, absolutely. So one thing that I see that maybe if a patient has achieved a very good CR, but not a negative PET-CT, some colleagues think that this patient needs a second line of therapy. And if the patient has achieved a very good response, is asymptomatic, I think there's a role for going on to maintenance and not going on to a second line therapy.
Okay, ma'am. Thank you, ma'am.
Thank you. One last question from the audience. Dr. Rajeshwarkar has put a question. How often CD20 expression is lost after rebiopsy when the patient relapses after 5 years, after having received only CHOP 5 years ago? And in that situation, if there is no CD20 expression, what will be your treatment protocol?
Okay. So this is a good, I assume that this patient received R-CHOP, not only CHOP, so received R-CHOP. And there's around 20% of patients who at relapse might have a negative CD20. This is an exclusion criteria for bispecifics. So it was an exclusion criteria for all the different clinical trials. And now it's considered a bad prognostic factor. I would actually consider it an exclusion criteria for bispecifics, but not an exclusion criteria to use, again, anti-CD20, because this CD20 is internalized. It is not disappeared, but it has been internalized. So it is not determined that these patients do not benefit from a new anti-CD20 therapy. So I would use anti-CD20 in patients with diagnosis, histological confirmation of lymphoma at relapse CD20 negative.
Thank you. One more question has come up. Follicular lymphoma and patient has got cirrhosis of liver. What will be your regimen of choice?
Oh, okay. Well, I would have to go over each drug to see the hepatic toxicity. The good thing about bendamustine is that you can regulate the dose, so maybe it can be used, but I have no recent experience on that. I'm sorry, I might not be able to give you the best answer for this question.
Right. So I have one experience. The neurosurgeon in our hospital has cirrhosis of liver, and he developed follicular lymphoma. And when I reviewed the literature, CHOP was out of question. So there were a couple of case reports of having used bendamustine. So I gave bendamustine standard dose with rituximab. One cycle he decompensated. LFT got deranged. He developed ascites. It took about 3 months to settle down from that. And obviously then there was no question of giving him bendamustine again. And we were really lost what exactly to do for this patient. At the moment, this patient is on LEN with the rituximab.
Yes, and also on these very difficult patients, we can always try rituximab monotherapy, because this gives us there are many institutions that have adopted rituximab monotherapy as first-line treatment, and although PFS is shorter, it is an effective treatment. So this is also an option.
Is polatuzumab effective in follicular? Polatuzumab?
No, I think polatuzumab has to be given to patients with diffuse large B-cell lymphoma, and I have no experience or no published evidence of the use of polatuzumab in follicular lymphoma.
Are there any more questions from anybody? There are nothing more in the chat box. So if none here, then thank you very much, Dr. Polaski. You spared very valuable time. And
thank you very much. Excellent questions. Very, very nice discussion. So thank you for this great invitation. And maybe I will see you in September in Bombay.
we're looking forward to it. Mr. Sumit?
Okay, thank you very much. Bye-bye.
Yes, sir.
Mr. Sumit will give the official vote of thanks.
Thank you, Dr. Astrid Pawlowski, for sparing your valuable time. It was an excellent presentation, followed by a very, very engaging discussion. Thank you so much. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, for providing us this wonderful opportunity, making us a part of this esteemed academic discussion and navigating this entire webinar in a highly proficient manner. I also thank all the discussants and participants who have joined us for this webinar. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. Thank you so much, everybody. Have a wonderful weekend.
Bye-bye.
Bye.
Bye-bye. Thank you.